evening's RLI Power Hour webinar titled Scaling Quality Improvement Within and Across Institutions. My name is Dr. Jennifer Nathan, and I'm co-moderating this evening's session with Dr. Bob Pyatt as we are co-chairs for the ACR RLI Power Hour webinar series. Before we get started, there's just a few logistical items that we want to review with you so you know how to better participate in this evening's event. So when you join this evening, you join through the Zoom platform. At the very bottom of your Zoom window is the Zoom control panel, which looks like this. There are two icons we want to draw your attention to on this panel. The first is the chat icon. This is an icon that you would click on if you're having technical issues. So you click on the chat icon, type it in the bottom window your technical concern, and our staff will reach out to you to help to resolve your issue. The second icon we want to draw your attention to is the Q&A icon. This is an icon you would use to ask questions of our speakers. You're welcome to submit questions at any point during this webinar. However, they will be collected and not addressed until we get to the dedicated Q&A session at the very end. One other item that we do want to let you know about is that this is a recorded webinar that will be available to our members at a later date, but also includes the participant questions as part of the Q&A session. So we just want to make you aware of that. So I'm now going to turn things over to Dr. Pyatt to introduce this evening's faculty. Dr. Pyatt.
Thank you, Jen. We have three outstanding faculty this evening, and we have Elizabeth Evans. I'll introduce first here. Elizabeth Evans, RT MBA, is the Service Line X-ray Senior Modality Manager for Advent Health in Orlando, Florida. She is responsible for clinical performance initiatives, meeting and maintaining regulatory requirements, and oversight of equipment purchases for the Central Florida region. Chirag Pargi, MD, is the Chief Medical Officer, and he leads the Clinical Operations Division with an emphasis on elevating Solis Mammography's industry-leading clinical quality. He also oversees the development of care coordination programs and the advancement of the company's long-term innovation and research agenda. As a practicing breast specialized radiologist, he also serves as the primary liaison to Solis's team of premier physicians and clinical partners across the country. Our third faculty member, Dr. Ben Wanke, is a general diagnostic radiologist with over a decade of leadership experience in the community hospital setting. Ben serves as the director of CT lung screening program and vice chair for quality and safety at the University of Rochester Medical Center Imaging Department, as well as being an associate professor of imaging sciences at the University of Rochester and chief of diagnostic imaging at FF Thompson Health. Ben is also helping us tonight as a co-moderator of the program. Okay, I'll now turn the program over to Dr. Wanke. Ben?
Thank you, Dr. Pyatt. I'm going to share my screen here, 1 second. Okay. Thank you very much for this opportunity to talk. We're going to be talking today about scaling improvement within and across institutions. So I'm going to talk today two things in my talk about, first, developing a local structured performance improvement program at your institution. And then second, what it means to participate in a national quality improvement collaborative and how those two things can be synergistic. So first, how do you build a performance improvement program at your institution? What are the key concepts? So it starts with the structure, right? And the structure for each of the projects that we do at our organization begins with what we call the project charter. And the project charter is really a document that helps to identify some key elements before you start a project for performance improvement. As you see, these gray areas are areas that we need to fill in before the project starts. We want to focus in specifically on a problem statement that's to be addressed by the performance improvement team, the goal in terms of how do you know when your project is successful, and the scope, any limitations of this particular project, whether it's just dealing with the CT department or just dealing with a couple of the sites within a broader organization. We want to identify members of the project team. I'll get into those in a bit in my next slide in more detail, as well as understanding how the project team and management team are going to interact and communicate throughout the process of performance improvement projects. The project team is critical to identify first. Most performance improvement projects are trying to tackle complex issues in a healthcare system, and complex problems are best solved by teams. Critical members of the team that we have identified include the project sponsor, somebody who at the organization who has the authority to provide the resources to achieve a specific goal. They can protect time for your individuals participating, your team members and your team leaders, as well as provide the resources for any funding that's needed to make those changes. A QI coach, a quality improvement professional who understands the methodology of performance improvement and can provide teaching and support along the way as the projects are progressing. A team leader, someone who is responsible for the daily the management of the team, the organization, basically serves as the project manager for the team and lead communicator for the team. A physician leader. There are many changes that happen in healthcare, and often it requires a physician to have conversations with other physicians and other healthcare leaders, as well as to provide some additional clinical resources to most projects. And team members. We usually like teams to be somewhere between about 4 and 6 people in size, so that leaves about 2 to 4 members on the team. And these are people that know the process well. They're close to the process. They may be technologists, nurses. They could be somebody in IT. They could be somebody from a different department. And oftentimes they're residents or fellows in a teaching organization as well. We often include additional team members. We include people on a project that don't meet with the team regularly, but they may support the team, such as somebody who helps the team to identify data or gather data, or maybe an IT specialist who can be who the team can work with if they run into a hurdle or a change in technology. All right, next is the concept of a standardized process for performance improvement. We believe in the model for improvement, or also known as the A3 model. This is a model where there's a single sheet of paper that explains basically the entire process of your performance improvement project. So it can be seen at a glance and shared very easily amongst team members and others, such as sponsors who are not on the team and regularly seeing those team meetings. It starts on the left side with really understanding the problem that you're dealing with, stating the problem statement. This is a what is wrong, not why are we working on something. Then it addresses a global aim. And the global aim is really, why is this important to the organization? A little bit of background about this particular problem and maybe what others have done to try to address it. Then it goes to a SMART goal, which is a concept of a specific target that is specific, measurable, achievable, relevant, and time-bound. The easiest way to understand a SMART goal is from what to what by when. So an example would be to improve, to reduce repeat CT protocols from 20% down to 5% within 6 months. Then you have an area where we have our current state and some analysis as well as data. So the current state is typically provided by a process map, mapping the steps of the current process as it exists before you try any changes or interventions. Here we demonstrate a run chart. This is a chart where data is being obtained on a regular basis. For this particular project, it might be daily, and you'll record performance over time. This is essentially your scoreboard, which tells anyone with a glance how the project is doing. We have baseline data that includes at least 8 to 12 data points, and then we work towards a goal. In this particular case, it's highlighted by a green bar. And you'll see that this project was very successful because there's reductions in variability and an increase in performance over time. You have an analysis of your current state that goes into things like fishbone diagrams and using subgroup analyses like a Pareto chart to determine maybe what are some of the root causes of your process. After you've done this left side of the A3, which is really understanding the current state, it takes about a third of any given project. We move on to the right side of the A3. And this is where we take key drivers. These are really those primary root causes and things that if we did consistently, we would achieve our goal or our target. And usually you can find somewhere in the range of 4 to 6 key drivers. And from there, you'll pick specific interventions, and they may address one or more of the key drivers. This is a great way to do some brainstorming and problem where we think of lots of different things that we might, lots of different approaches that we might take to try to solve a particular problem. So we're not starting with one idea in mind, and if it doesn't work, we're stuck. So we have lots of ideas here. We want some idea addressing each of the key drivers so that we have our best chance of success. And it might take numerous attempts in a PDSA type cycle to achieve our goals. All along the way, we want to think about sustainability of the program, of our results after the active phase of performance improvement is done. So we think about process owners, who's going to take ownership of this afterwards, and how are we going to communicate any changes to them, and how are we going to make sure that they are bought in and they're going to continue the process after the performance improvement is done. And we include some things like reliability levels of the individual interventions. Things that are more highly reliable are going to work without human oversight and potential for error or people forgetting to do things over time, and the need for repeated training, like embedding a process within an IT system. And then we would also monitor the progress, whether things are progressing and completed, or whether interventions have been tried and we decided that they've failed and we've stopped those particular projects, or they've maybe hit a barrier. And here's a blank model of an A3 for you that I've left in the materials that you'll get at the end of the session. Next, it goes down to the sustain plan, which is another structured way to demonstrate who's going to own any process that is changed, so that we have a better chance to think about making sure that these interventions and changes are going to stick and not fall back to our prior state when the project is completed. The next important process in a structured performance improvement project is skill development. So our teams are only going to be as good as their knowledge level is around performance improvement methodologies. And so we believe in just-in-time training. So you give the team skills. Your quality coach will teach the team skills as the projects are progressing. As you're moving down the left side of the A3, you're teaching them how to do the next step that they'll be doing in that next week. This model is well documented through the Stanford Wright program. Dr. David Larson, as well as others, have really made this a gold standard around the country for performance improvement. And I encourage you to read this article from Radiographics. Stanford is also kind enough to leave their tutorial videos. These are well done. These are on YouTube. They're free to access. And you can look in and use those to help do some training, particularly early in the process as your team is still learning the performance improvement process. And it just makes it a lot easier and quicker to do some high-level education of your teams. There's about 20 videos there that reach about 5 to 12 minutes in length. And finally, the support is the last thing that I think you need to provide for a structured performance improvement program. You'll see that I use the 4 S's, which I think are critical. So how can the quality team support performance improvement projects? They can work with administrators to identify projects that they support. So we're picking things that the administrators believe in are going to help are going to provide meaningful changes to the organization that they will believe in, and they will provide resources and time to fix. You can assist in team building, help make sure the right members are on those teams. You can mentor the team leaders to help give them the skills for leadership skills and communication skills that they're going to need to be successful running their team meetings. You can help the team with data visualization. This is a tricky topic. There's many ways to look at data, and understanding data variability is key to performance improvement, to know when you've actually achieved something significant. Also identifying barriers and then escalating those back to the sponsor or someone else in the organization that can help to overcome those. Ensuring accountability of the team, that they're moving along at the right time frame, so that that the team will be completing the project on schedule. Celebrating success can't be overlooked. When you do finish a project and you succeed, You want to celebrate that success, share that message across your organization. Performance improvement is contagious, but that message has to get out. And then share your results nationally and throughout your organization. Let people know of the good work that you're doing. All right, so that's my quick overview of how to build a performance improvement program. And I want to transition to participating in a national quality improvement collaborative. Specifically, I'll be talking about the American College of Radiology's Learning Network, which is now 2 years old. And I wanted to touch base about what is a learning network first. It is a deliberate organizational structure that facilitates meaningful improvement across multiple organizations. These are organizations who have the capabilities, desire, and value to organize around a common goal. They develop protocols, processes, and infrastructure that allows multiple actors to collaborate together. And it creates commons where the actors accumulate and share knowledge and tools with others in the network. The American College of Radiology's Learning Network has 4 improvement collaboratives, each of which is made up of local sites aiming to solve common problems, to develop, validate local solutions, and learn from others and develop global approaches for lasting change. We have a collaborative on recommendations follow-up. This is incidental lung nodule follow-up, which is one that I lead. The prostate MRI image quality, mammography positioning, as well as lung cancer screening. The Learning Network's intent is to teach a structured process for improvement, to help organizations get their projects done on time, to develop measures of success, which can be ultimately shared with others and potentially used as national measures of performance improvement, and to collaborate across sites to facilitate collaboration. They utilize the Empower or Improvement Performance process. This is modeled after the Stanford Wright program, but is expanded upon it. We use a 10-session training program that really teaches the theory and tools of performance improvement. We provide time to discuss concepts, collaboration. We facilitate collaboration, and we provide access to content experts. We also have sessions dedicated to measured development within the Learning Network, where we gain consensus on what is quality within a particular area or problem. We train people to collect that data accurately and consistently. We validate their data collection. We train people to use run charts to demonstrate that data and share their performance with others so that we are comparing apples to apples from one organization to the next. And we build community by working with each other to share successes and failures. We have a process called Walk the Wall, where we have project report outs that occur about every other week, where a quality improvement coach or team leader will present the project update to the quality improvement director or for the Learning Network and the collaborative physician leader. At this time, we are identifying barriers that teams are having and helping them to overcome those. We are we are validating data. We are sharing best practices between sites. So all the collaboratives are participating in these walk the walls and listening to the performance and ideas of others in the collaborative, as well as their successes and failures. And then we ultimately rate the projects on a progress scale. Our progress scale starts at 0.5 and works its way up to 5. 5 is sustained world-class performance. And to graduate from the Learning Network, you have to have at least a 3.0, which means your initial test cycles have begun and you have evidence for modest improvement. Here's an example of how we might be scoring teams over time. So each week they're scored, each 2 weeks they're scored as they move through the Learning Network. And some organizations will be a little bit faster than others, but ultimately almost everybody gets to the graduation level, and some sites will move on and move towards either sustained excellent goal or world-class performance, and can share those tips and tricks with others in the collaborative. So the Empower process we use to improve performance locally, but we're teaching those QI methodologies. We're defining the problem. We're measuring performance. We're deeply understanding our current state, what we do well, what we don't do well. We develop, test, refine, and implement interventions, and we ensure sustainability. So that's the active phase of the projects. And then we transition to the Learning Network, which is the learning community, where we deepen our expertise amongst people that have gone through an active phase. We help sites develop world-class performance, that we share those ideas with other sites. We're going to be publishing data about our learning network experience. We are deepening relationships between collaborative members, whether they're in the first cohort, the second, or the third. We are currently recruiting for our third cohort, and working with our second cohort of sites. There are anywhere between 3 and 6 sites per cohort of each of the improvement collaboratives each time we cycle through in about a 6 to 9 month cycle. All right, so what makes somebody likely to succeed when they work with an improvement, with a national quality improvement collaborative like the ACR's Learning Network? You have to have department leaders who are supportive of and willing to manage change. You have to have a team of engaged frontline staff, including a physician leader who can participate in the program and do the project work. You need an improvement coach with some QI experience. And we do have some support for teams that don't have that, but it certainly helps. And ultimately, if you participate, you will develop that through your participation. We have the ability to commit to at least a 6-month training program or active phase of performance improvement. We deal with an organizational sponsor that can provide time and resources for the projects, and basically a desire, a culture of people who are willing to join a community of improvers who are able to collaborate and create the best experience for their staff and patients. Thank you. We'll be moving on to our next speaker, Elizabeth Evans, and I will stop sharing.
Good evening. Thank you, Ben. So my part of the presentation, I will be speaking on spreading and scaling change across institutions. Throughout the presentation, we will discuss leading change across large multi-site institutions. We'll learn to recognize when to scale down in order to make small tests of change, and how to scale back up once those small tests of change have been proven to work. Before we start, though, I'll give you a brief outline of the organization I work at, because I think that this is important to understand that how we do things within our very large organization could work very differently in a smaller organization. The principles of performance improvement remain the same. The differences would be in how each organization decides to scale projects. So at Advent Health, we operate from small community hospitals to large urban hospitals and everything in between. In Central Florida, we spread across 7 counties and see more than 3.4 million patients a year. There are 34 imaging and diagnostic locations with 150 radiologists and growing. At times, results from projects being worked on in the Central Florida region are spread throughout the organization. This means implementing change to locations in 10 states across the US. I tell you this because it's important to understand who your stakeholders are and how fast they expect to see results. It would be impossible to implement change across all of these locations at once. How we implement change, our largest hospital in Orlando, Florida, shown here on the left, is vastly different how we implement change at our Manchester, Kentucky location, shown here on the right. As leaders, we tend to move straight from learning there is a problem to offering solutions to said problem. We often forget the important steps in between. So how do you lead change through all the congestion? The first step is going out to see what the problem is. Within a large-scale organization, that can be hard. This is why it's important to decide when and how to scale down. We'll talk about this in subsequent slides. While out gathering information, it's important to talk to the frontline team members. Ask them why they feel the issue is occurring. Gathering empathy from frontline team members can be very helpful in understanding what they're struggling with. This gives you a starting point with truly understanding the problem. Collecting data is also equally as important in order to prove or discredit theories. After all of these steps, you have to decide how to scale the project. Do you include all locations, all scanners, all exam types, all staff? In 2020, when we were working on this project, missing images represented the highest CT quality feedback from our radiologist and was the top quality improvement opportunity in CT at Advent Health. 0.75% of CT post-processed exams in our 3D lab had images missing. CT studies submitted with missing images postpones interpretation, causes rework, delays patient care, and is the radiologist's biggest pain point. 700 out of 3,000 QAs between April and June in 2020 were due to missing images in CT. Audits from our 3D imaging lab staff who post-process CT exams at Advent Health were used to measure performance. The project goal was to reduce the percentage of exams with missing images from 0.75% to 0.30% for studies post-processed in the 3D lab by December of 2020. This would result in a 60% improvement. The SMART goal was determined by reviewing radiologist and 3D lab technologist feedback within our QA tool. Using the 5 whys, our team concluded the root causes were AutoSend not being consistently turned on, CT technologists having to split images to go to multiple orders, the PACS workflow was not clearly defined. From this data, 5 key drivers were formulated, which were imaging send automation, clear and consistent tech complete process, building lean order sets, and implementing lean protocols, and to have a clear process for PACS servers assigned. Based on each key driver described, specific solutions were put in place to meet our goals. The most impactful interventions were automation, creating a combination order, and removing curved coronal reformats from the cervical spine protocol. We'll discuss these in further detail next. An important intervention was verifying image send automation was available on all of our GE, Philips, and Siemens scanners across our North and South divisions. The next step was to confirm that each campus had AutoSend turned on the CT units when it was appropriate. Based on radiologist and technologist feedback, our team created a new combination order for CT chest, abdomen, and pelvis. Before the combo order was created, the providers had to place 2 orders, and the technologist's workflow was to split the images by study order, which we identified as waste. After review of the CT spine protocol, it was determined the curved coronal reformat was only needed for patients with kyphosis or upon radiologist request. We were able to move this process for being performed on the CT scanner from the frontline CT tech to our 3D lab team, and then technologists on the front end didn't have to do it. Post-processing on the scanner takes considerably longer than it does for our 3D lab team who are specialized in performing this type of work. I learned my lesson on scaling during this project as my leader insisted on including all sites within Central Florida. This included 13 hospitals, 14 outpatient centers, and 5 freestanding EDs. There were a total of 72 CT scanners we included, which meant a lot of data and staff. It was totally unmanageable and very challenging to test change. Partway through the project, my partner and I made an executive decision to only include a handful of sites when testing change. This made it more manageable to see if the changes we were putting in place were making a difference. We were able to see in our data quickly if a change wasn't working and could cut that idea, then begin testing other interventions without much trouble. It was easier to get staff buy-in and on board with testing. We were able to talk to them throughout the trial periods to see how the changes were working. We could quickly pivot by deciding to scale down. In the run chart above, you can see that we did not start seeing true change until we scaled down to 2 sites. By the end of the project, we were able to take all the successful changes back to the other sites not included in the pilot testing and scale back up. Second project I'll share is an example of scaling. It's from the first cohort of the ACR's Learning Network Empower program last year. This was another large project with lots of team members, including 3 radiologist residents and a medical student. Having such a diverse group proved to be key to this project. That and how we chose to scale the project right from the beginning. The SMART goal for this project was that non-diagnostic MR prostate diffusion exams can lead to deficient quality images and repeat studies. Our goal was to improve the percentage of MR prostate exams that met PI-QOL criteria from 89% to 94% by November 2022. This goal was determined by performing baseline quality assurance audits. A structure was set by the cohort to ensure all groups were performing audits based on the same standards and criteria that Dr. Wanke spoke of. We decided from day one that we would scale this project down. We only included 4 campuses who all had Siemens 3T scanners. This gave us the opportunity to test change on like units and with small groups. We were able to gather empathy from all frontline team members easily, and they could get us feedback on changes live time. Using the 5 whys, we concluded our root causes to be insufficient clarity around what constituted good image quality, a need for a bowel prep, DWI protocols were not standardized, and the protocols were not optimized on the scanners. From this data, 4 key drivers were formulated as shown on the slide. Based on each key driver described, specific solutions were put in place to meet our goals, and the most impactful interventions defined here on the right. These were adding reference images to the protocol, implementing a bowel prep, standardizing scheduling questions, calling the patients 2 to 3 days prior to their exam, using motion reduction techniques, and standardizing the protocol and sequence order on the scanners. In order to gain alignment around image quality, we added good and poor quality reference images to the protocol. Our Siemens Flex coach visited each campus to load the protocol on the scanner and provide education on the new expectations. For our second key driver, we knew implementing a more effective patient prep was going to be crucial. This included 2 saline enemas, dietary restrictions, and providing coaching the day of the exam. Top ordering providers were informed of the new prep and instructions. Last intervention associated with this key driver was to standardize scheduling instructions and implement them in Epic. We standardized our DWI protocol for when to call a radiologist. Our sites found success using the compression belt to reduce breathing motion and helped patients remain still during prostate exams. Calling patients 2 to 3 days prior to the exam helped clear up any questions about the prep and improved compliance. After gathering data from the PI-QOL audits our residents were performing, we quickly recognized that the area we had the biggest opportunity of improvement was in our DWI sequence. As any MR tech or radiologist will tell you, this is the money shot. This graph shows what our team was most proud of at the conclusion of this project. We exceeded our DWI goal of 75%, and we're trending around 82% optimal quality at the conclusion of this project. I firmly believe that by scaling down, we will see change early in the project. You can see on the run chart, we started seeing improvement less than halfway through the project. This gave us the boost we needed to exceed our original goal. There were 3 key things we learned throughout both projects and have taken with us into other projects. Number 1, don't be afraid to fail. Remember to fail fast, fail small, and fail friendly. Resist the urge to solve the problem up front and let the process work. And lastly, narrow your project scope to small tests of change and intervene sooner. Thank you, and I'll hand it over to Dr. Pargi next.
Thank you. Well, that was a great presentation. I'm going to talk about, my name's Chirag Pargi. Hopefully you guys can see my screen and hear me. I'm going to talk about our experiences in the Learning Collaborative. I am the proud Chief Medical Officer of Solis Mammography. A little bit about us. We are on par this year to perform more than 1.5 million mammograms this year. We have well over 100, well north of 100 centers, and we've been doing this for 30 years. We've accidentally become experts of breast imaging at scale, which is an interesting creature, right? We have to figure out solutions that work across communities, across markets, where we can provide the highest level of mammography services and breast imaging and women's health services across the country. So we joined the first cohort last year. Now I will be fully transparent, and I admitted to this at Stanford. When we signed up for this, I thought we were going to blow it out of the water day one. I thought we were going to get a certificate saying, hey, you don't need this. You guys are excellent. We're a focus factory. We focus on women's health. We were quite proud of our work. So we had 2 teams, and I was proven wrong. I'll lead with that. We have 2 teams that were participated in the first cohort. The first team was located in Denver, and the second team was in Bel Air, Maryland. For those of you that aren't as familiar with geography, those 2 are not near each other. And our corporate headquarters are in Addison, and I live in Houston. So we made it perfectly complex and made the litmus test to see how fast we could mess this up almost from complexity. But despite that, we had a really, really positive result, and we really enjoyed our processes and just enjoyed our time within this collaborative. So this was the kind of shot in the arm that really made us realize that there's always room for improvement. Right. So as part of the process, we did an internal audit. We looked at our mammograms, 236 mammograms, and by major and minor criteria. And I'm going to touch on this later, that all of these mammograms would likely have passed our MQSA audits. And so that standard we would have exceeded. While we would have exceeded that, when we looked at it with a more critical standard and with a more critical eye, we had a 55% pass rate, which means we had a 45% fail rate. For our mindset, for our pride, for how competitive we were, we looked at this and we were totally depressed. Both teams wanted to hang up the towel and say, I should just quit doing mammography altogether. It was really, which at some level is amusing, but at some level, it shows how much we care. And they carried this energy, this passion throughout the collaborative, because they were able to rechannel this frustration into a competitive drive to get better. And I was so proud to see this unfold, and to see that disappointment that started off in the beginning unfold into more excitement, curiosity, to a contagious energy, right? And that really was our experience. We did have to slow down. We did have to go through the process. And now being on this side of it, I can appreciate what Dr. Wanke says. You have to focus on the what, and you have to go slow. You have to be objective. We as clinicians just want to go fast, and we think we have everything figured out in our heads and can just use intuition and just shoot from the hip. That's not what we did. We had to go slow, sometimes frustratingly slow. And we broke down the what's of our process, and a process that we had just gotten so used to, we could do it at a spinal level. We had to stop and think about it, and where our challenges were, where our friction was. And this was a very enlightening process in deep introspection. We went through all of these different reasons why we may have not gotten the optimal patient positioning, right? And so there's a lot of them. All of them apply. One of the big ones that really kind of woke me up was this feedback process, in that our feedback was limited to our MQSA, our EQUIP, and as long as we were passing inspections, we thought we were doing an outstanding job, which by some metrics you can say you are, but there's still room for improvement, right? And we would occasionally do technical recalls, but that would or technical repeats, but in our field, that typically happens when imaging is just egregiously bad. There was, and I say that to spotlight that there was little emphasis on improving beyond abject failure. If the mammogram was horrendous, okay, we'd recall the patient, and maybe that technologist would find out, hey, maybe I could do something better. But outside of that standard, there wasn't improvement beyond that threshold of abject failure. And so this was a big one for us, that, hey, just because we're passing accreditation doesn't mean there's not room for improvement. This was a big wake-up call for us organizationally. So then we tried a bunch of different things. One kind of comical story was the patient education. You know, we sat together, we thought about it, we said, what's going to improve? We're going to come up with this marvelous patient education sheet. It was beautiful. It was well written. It was eloquent, everything. It didn't work that well. You know what did work well? We put a pink ribbon where patients' feet should go. And that was amazing. That had amazing results. So it really was a good parable in dogmatism, right? The idea that sounds really good, oh, this is going to work, didn't. And the simple solution worked. And we've since tried to replicate that because it's a simple solution across our enterprise. We did work on technologist coaching. The technologists were working in a silo. Even in our big operation, the technologists were not getting proper feedback. They weren't getting championed and encouraged with positive energy to change, to get better. That was something we directly worked on. As a big organization, we're constantly onboarding new technologists. There's a flux in our organization, and there wasn't a structured onboarding process for new technologists, something we knew probably existed, but we weren't directly aware of. This was a big one. Now, alignment on imaging quality. If you ask 10 different technologists and or breast imagers and or anyone in mammography what quality is, you'll get 40 different answers, right? That was what we experienced. The first few calls were painful because we could not come up with consensus on quality. So you have one technologist in one center over here thinking they're, superwoman doing the best quality of another technologist here, and they have differing standards of quality, differing standards of aggrandizing expectations and self-serving thoughts of quality, right? And so we're living in our own silos, and we were all legends in our mind, right? Getting on the same page for quality was a big step for us. It really helped us start measuring objectively and evaluating our audits in a more objective, slower, quantitative manner, right? And I could not speak enough about the effect of empowering technologists. This was one thing we learned, was we were not engaging the curiosity of our technologists nearly enough. And I hope to show you that on our subsequent slides. This is the first few weeks. So we started, this was our baseline right at about 55% across both centers. We immediately jumped to our target goal of 85%. And that happened, why? Directly because of empowered techs. The technologists got more curious. They're more aware. They were trying more. They were giving each other feedback. They felt like they were in charge. And that was a common theme that we learned throughout this cohort, and we learned to harness that. And that's a quality that we want to harness across our enterprise, because that directly, in our opinion, translates to better pictures, right? And then the exciting part that I could not be more proud about was we were able to sustain this improved imaging standard for above 10 weeks. And it's still hard. It's hard to continue to audit in our busy centers, but we're still proud of maintaining this benchmark of quality. And like I said before, the linchpin, especially for this cohort, was technologist empowerment. It was fascinating to see the change in attitude, where there initially was a little complacency, or yeah, I got the image, yeah, okay, this would pass MQSA, to people got really curious, they got competitive, they got interested, and there was this brand new job satisfaction as a result when you start really focusing on the nuances of your role. And we saw that organizationally, and it went all the way up to our executive team. We had the distinct privilege of now being in cohort 2. Now, I'd love to say it's all apple pie and roses. It hasn't been. There's been some big challenges. In cohort 2, we've been really focusing as an organization, how do we take this across 100 sites? There's no way we can do 100 centers through each of these learning collaboratives as much as we want to. We're limited by time and resource, right? So we are really studying cohort 2. We picked 3 sites in the greater Houston area. And I have to admit, one of them, we lost some key technologists and some center directors just due to the labor market, and we had to consolidate 3 of them into 2. It's a reality of community practice of mammography. It's busy. The labor market is uniquely challenging right now. So we've learned to factor that in. How do we continue to improve in a tight labor market? That's something that we're thinking about, right? And as we come to conclusion on this cohort, we're really thinking of how can we do this fast and at scale, which it's challenging, but it's an opportunity, right? We are trying to take the best of the learning, which is hard because it's also rich, and how do we reduce it to elements that will get us the most meaningful jumps as quickly as possible. That's the next level of chess that we're playing, and it's really fun, and it's opened up a blind spot that we never thought about. So I could not give enough compliments to our team and to the ACR for their patience with us as we worked our way through this process. But there was so much learning that happened through these first 2 collaboratives. I fundamentally think change is a healthy antidote to complacency. As an organization, we did good. We did good enough, and we thought we were excellent, right? Because we were passing every MQSA inspection. Our technical repeat rate was low. But that's still a form of complacency. We weren't improving beyond that threshold, right? And so changing, trying things, even if they fail, like the patient education sheet, is a necessary and healthy antidote for complacency. And that can be extracted to much larger than just this collaborative. It's a larger kind of metaphor on how to improve organizations, right? Ambiguity and subjective self-evaluations of quality are not good enough. Absolutely. We all thought we were legends in our mind. We all thought we were the LeBron James of mammography, or the Michael Jordan, depending on who you want to call the GOAT. But we were all so proud of ourselves that we would subjectively evaluate ourselves. And when you get an objective yardstick, that's when you can really start to measure improvement. The process of improvement, as Dr. Wanke says, we're really required a slowing down and focusing on the what. We had to stop, slow down, and think about what our actual barriers were, which is hard to do in a busy practice. We perform mammograms at 15, 20-minute intervals, right? It's a busy clinic, but to slow down, you have to almost unlearn the things you learn clinically to get meaningful qualitative improvement. And then you can engage in action. Then you can get in curious action, where you get to try different types of styles, different changes to see what works and what doesn't. And change at scale, and this is something I wish I was an expert in, but we're still wrestling our way through. Change at scale is very different. What works in a clinic, not to trivialize change in a single clinic, that's obviously has its own challenges, but to get it generalizable requires a very open mind and an ability to extract the learnings and simplify and grow at scale. And this is something that we are excited to do at this next level. That our experiences in this collaborative have really given us this infectious kind of optimism and just contagious energy that anything is possible. If two clinics, one of which is in a smaller part of Maryland, can change their culture, inside their culture, to be one of sustainable optimism and hope and just excitement to take better pictures, which will translate to earlier breast cancer detection, I think anything is possible. So we've really enjoyed our experiences, and we're excited to take on new challenges to figure out how can we take these learnings and grow them and infuse them into the fabric of our organization so that we can continue to get better and continue to change. Because I think that's it's a healthy kick in the pants for an organization like us, or at any scale, to avoid complacency. Even if all metrics say you're doing fine, it's necessary to constantly improve. And the last point, tight labor markets are real. I'm sure all of you are experiencing it, but they are just opportunities for creative thought. And I fundamentally believe this. We are working our way through this as an organization, but that's not an excuse. It's not an excuse not to get better. And we're excited to kind of learn in the upcoming years how we can infuse this into our work culture. And with that, I'm going to turn it over to Dr. Wanke again.
Thank you so much, Dr. Parkey. Love that story. Love hearing how complex that organization is. You're all over the country. You're doing the same thing, but you're doing it differently in all different places in the country, and how it's not so easy to have a standard process. And
Absolutely. Thank you.
Dr.
I
Nathan,
just sent that last slide to my team, Dr. Parkey.
Okay.
I love it.
Fantastic. No, it's raw learnings, right? It comes exactly what we were very much freshman students in a college class with this experience, and it was really good for us. It was really healthy for us to kind of infuse some curiosity and look back at our system and say, hey, what would a first year college student say about this? How would they look at this? And it really was fun.
All right, so this is the time we open it up to questions and answers from everybody in the audience here. I know you guys have been listening patiently, and I know there were 2 questions that had gone through the chat that had answers. So I think we'll just touch on those really quickly in case anyone hasn't had a chance to look. The first question was about there's a clinical issue that we'd like to set up in a learning network. Is there any way to get guidance or resources to help create this? And Judy Burleson from the ACR's quality team is here as well and helping to answer some of the questions. We are having, within the ACR's learning network, there is a cohort 3 beginning in January. We will have a sort of a potpourri collaborative where it's bring your own project, and you'll get the same ACR learning experience dealing with whatever problem your institution is trying to deal with. You're going to still get all the benefits of the training and the Empower program. You're going to understand and see the structure of the learning network, but you're going to be able to deal with a project of your choice. I imagine this is going to be very popular and potentially competitive to try to get into this collaborative, but I certainly do encourage you to apply. In terms of setting up your own learning network, I would tell you that it is much more difficult and complex than it looks, that it may seem from afar. It takes a small village to make the ACR's learning network happen, and we're still getting better at it. And this is 2 years in, so it took 6 months of planning, and now we've been in it for 18 months, and we continue to work, improve, and learn new things as we're doing this. Learning networks are fairly common around the country in other specialties, but we really haven't had one in radiology to date. We've participated in some others, but yeah, so I would recommend you participate in a learning network before you try to create one. It takes a lot of resources. This was a 3-year project supported by the Gordon and Betty Moore Foundation with a multi-million-dollar grant to make the ACR's learning network happen.
Yeah, I would say if you don't have something in place now, I think it's very deceiving what actually goes into, going through a full process improvement. Again, I mentioned in my slides, as leaders, we tend to go from hearing that there's a problem and then saying, hey, I think this is the solution. And for true performance improvement to stick, and for, things to not backslide into how they were, you really have to go through that whole cycle. And like Dr. Wonke said, this program teaches all the different aspects. So, if you have someone that's kind of a newer PI coach, this is really good because they can partner with experienced PI, QI coaches. They really get that training. And so even though this is a long program, I think it's super beneficial because, you can have someone at every level in this learning and then be able to spread it from there.
Yeah, I agree entirely. I mean, I think there's different levels of problems, right? If there is an obvious problem that has an obvious solution, yeah, maybe that can just be a simple checklist style. But a lot of these problems are insidious, they're systemic, they're behavioral, and behavioral change is really, really tough. And we are very good at imaging, and we're very good at very specific, science related tasks. But this requires really understanding how to change. And for me, that's a lot of things that I thought I knew. I had no idea how to actualize. So I think it's a very good process for anyone even slightly curious in making a big change, because the checklists don't do it, memos don't do it, emails don't do it. Having a really deep understanding of what before why and then how, it really allows for meaningful change.
All right, there were a few questions that we received from others prior to the meeting, just based upon the topic and the learning points that we had sent out there. And I think a couple of these are relevant, and I'll ask these to the other panelists. These kind of dovetail with each other. One is, how do I improve quality at my institution? And the other is sort of, how do I create this culture of change within an organization? I talked a little bit about the structure of a quality improvement program, but I really didn't talk about how you get one off the ground. Maybe what types of resources do you think are necessary for teams for organizations that are looking to build a program, and how might that vary depending upon the type of organization you're in?
Absolutely. I'll start off. From my experiences, you have to really understand how to motivate leadership. If you can get the right leadership support and buy-in from the key stakeholders to take a chance on any type of qualitative improvement, I think that helps. That helps considerably, especially in an organization of our size. We had leadership support to go out there and learn about how to get better. And that was after that point, it gave us kind of the cultural adoption of, hey, we're going to try this, right? That's step one. Hey, we're going to try this, and getting the key buy-in to, we will at least take a chance on getting better. And after that, I mean, a learning network is obviously a great avenue and vehicle to to get into that mindset, because you get coached on the mindset and the behavioral changes that are needed. It does take time and resource, and you need people to commit their time from busy jobs to really dedicated improvement. And they have to be a little vulnerable. I'm not going to lie. They have to be vulnerable to improve, because you have to break down a little bit. But most of that happens with motivated adoption. That's been really my my perspective. I don't know if somebody else has a different perspective.
Yeah, I mean, I think, I agree with what you said. And I mean, I think I'll build from there because, again, it goes back to a lot of times, there's that perceived idea that something is a problem. So, how do I improve quality is really, you have to start and you have to have the data. So whether that's, pulling data that you already have or performing audits to see, is something really a problem? Because sometimes we think that something is a problem, and in all actuality, it's really a tiny, it's something very small, and there's other things that are a bigger problem. So after you pull the data and you see that something is a problem and you say, okay, we need to work on this, just like Dr. Pargi said, you have to get that someone that will sponsor that in leadership, that says, yes, we back you up. We will help you, talk to whatever leaders it is. We will help you get radiologist support. We'll help you get frontline tech support. We'll help you, get nursing or whoever needs to be on the team for that project. And then, going out and seeing the process. So I think, there's a lot of different things, involved with that. But yeah, definitely you have to have, sponsorship and buy-in from the team that you're wanting to change, whatever the process is. If it's, you're wanting to change something for the radiologist, you have to have radiologist buy-in. If you're wanting to change something with the technologist, you have to have technologist buy-in. You have to get them to understand the why and believe in the why and say, yes, we feel like this is a problem too. Let's make that change.
I'm going to take a stab at that question as well. So as somebody who took over the role of vice chair for quality, at an academic organization that has a number of community sites as well, my first goal was to build a culture of continuous quality improvement. And that required us moving away as a quality team from just doing regulatory issues and responding to RCAs and things retroactively, and honestly filling out the paperwork of OPPEs and other measuring performance, but not really trying to change performance. We started to partner with operations. In particular, we worked with a lot of the population health initiatives. So I've done a lot of work with tracking of incidental findings and building systems that help to improve the follow-up rates of incidental findings. That helps to improve safety for your patients, but also drives revenue. And those, in that type of project. The other one that we've done successfully is lung cancer screening. It really expanded the percentage of patients that are being screened in our lung cancer screening program. That is a population health goal, but that also is an operational goal that leads to significant revenues. If you can make the business case around that, now the institution realizes you're creating value, right? So these performance improvement projects, the goals are usually three-pronged. One is to improve safety and patient care. The other is to improve efficiency, and the last one is to drive revenue. And you can demonstrate value. And when you do your projects, please measure the value and share that as part of your message with your administration, because the people that hold the checkbooks understand understand value proposition, and they will provide you more resources if you can demonstrate a track record to do so. Our quality team just grew by one FTE this past week because we were able to demonstrate the value of what we've done with the resources they provided us. And so that success builds on itself and ultimately allows you to get the resources to do more good work, and to spend more of your time doing performance improvement projects and less of your time just simply doing regulatory issues and keeping up with the status quo. I will also say that participating in the ACR Learning Network is probably the easiest and best way to understand the skills and learn the process of performance improvement, learn a structured process. They've got extremely knowledgeable people on these in the Learning Network who are out there doing trainings and teaching of all of your staff. It's essentially like getting free or very inexpensive consultants to come in and train your teams on how to do performance improvement. And your QI coaches will get additional training, and they'll come away with enough skills that you can go in and then say, we're going to do our own projects separately with the knowledge, skills, and structure that we've learned from the Learning Network. So that's why I think they're very synergistic. You can actually dip your feet into a National Quality Improvement Collaborative and take those knowledge and skills that you learn and go back and apply those and build your own performance improvement program after you've done the ACR Learning Network. So we kind of work both ways. All right, Dr. Nathan, any questions for the panel?
Well, any further questions for our faculty? We did have a few from earlier we could ask. Pull some of those up. Maybe we have time for maybe one more question.
Yep, there was another question in the audience here that says, was there any cost associated with joining the Learning Network? Right now it's grant supported, there is no cost. Ultimately, learning networks fund themselves. There's relatively low cost. The ACR will continue to support some of the learning facilitators that create the commons, but there may be some small costs on an annual basis to participate in a standard learning network. All right, sorry, Dr. Nathan.
Oh, no worries.
Number 24 was a really good question, Dr. Nathan.
Perfect. Well, this was such an informative webinar. I really thank all of our moderator, Dr. Wanke, and our faculty, Dr. Evans and Pargi, for participating in this webinar. So I'm now going to turn things over to Dr. Pyatt.
Thank you, Jen. And I'd like to thank our three fantastic faculty this evening for this program. And if you'd like to know a lot more about quality and these types of projects, we would like to let you be aware of the Quality and Safety and Informatics Conference in San Diego, October 24 to 26. We also would like to thank the Commission on Quality and Safety for co-sponsoring tonight's program. The agenda and registration details for the conference are at the ACR website that you see listed. Next slide, please. So thank you again for attending tonight's program. Please share your feedback with us. You'll be getting a post-webinar survey and a recording later this week. And to update you, in October, that is our next program on empowering radiologists with AI. This program is co-sponsored by the ACR Data Science Institute. Excuse me. And is scheduled on Tuesday, October 3rd from 7 to 8 p.m. Eastern Time. You can register for this and other programs at the website acr.org/powerhour. Again, I'd like to thank our faculty for tonight's fabulous presentation and also to the audience for attending. Thank you, everyone, and have a good evening.
Thank you. Appreciate it.